I work with the Susan G. Komen Breast Foundation here in Peoria, and we see about 350 breast cancers a year. And a significant number of those ladies come to us for mastectomies and various forms of reconstruction. Prior to the advent of SPY, I think like many surgeons, I was just using fluorescein as a guide to skin viability and then clinical assessment, which, as we all know, is not terribly accurate. And then we've been using CT-based angiography to pick up where the perforators are lying. And I still use that for patients who are going to have a deep flap, for example. It's still a very useful adjunct to determine the exact location of the perforators, but it doesn't tell you, of course, which of those perforators is necessarily the major supplier to a given skin area. So those are the only other technologies I've used. Now, for myself, I was thrilled the first time I saw the SPY camera, because this represented for me the pinnacle of what we've been looking for in plastic surgery, something that gives us real-time, instantaneous evaluation of muscle and skin and fat perfusion in real-time intraoperatively. And you can base clinical decision-making on it. You can change your whole direction of a procedure sometimes based on what the SPY is doing. And the other thing it's given us is a tremendous adjunct to assessing skin viability in mastectomy flaps. So it's been a tremendous adjunct. I use it routinely on all mastectomy patients now to assess the perfusion of the skin flaps, regardless of what technique I'm using for the reconstruction. I'll do a basic SPY imaging at the outset just to see what the perfusion's like. And you can often tell on that first image which side tends to be dominant. You can see the speed of the blush and the zonal perfusion changes and see where your prominent perforators are. Even though you may already have diameters and locations based on the CT angiography, this gives you, I think, a more precise decision intraoperatively as to which vessel to use. The SPY camera has been so useful in determining what skin is viable, and that's an application that both microsurgeons, autologous tissue surgeons, and non-autologous surgeons can use in their daily practice. And it's been a tremendous adjunct for patient safety. We've virtually been able to eliminate skin necrosis of mastectomy flaps as a clinical problem when we listen to what the SPY says. I think one of the biggest issues we have as clinicians is trying to override that clinical judgment, because you imprint the skin with a hemostat handle or press on it, you see capillary refill, it feels warm, you think that skin is going to be viable, and yet the patient may have a background of smoking, and then you keep that skin and 48 hours later you've got a demarcating skin island that's starting to blister. With the SPY technology, that's been virtually completely eliminated. But you've got to override that initial sense of relying on clinical judgment and put your faith in technology, which is sometimes hard for us as surgeons to do. And the assessment of skin viability for mastectomies is very reassuring. It's a tremendous heartache for both patient and surgeon when his patient's left with blistered skin post-operatively and may even lose a reconstruction because of it. And you've made that decision based on clinical judgment, which proved to be wrong. So there's that reassurance. When it comes to the autologous reconstruction itself, be it a deep flap or a pedicle tram flap, being able to look at the zonal perfusion, and clinically we've always said in a pedicle flap, zone 1 and zone 2 are usually pretty good, tip of zone 3 and zone 4 are usually not good. We discard them. This gives you even more reliability in making that judgment. From the patient standpoint, there's the obvious reassurance of having a reconstruction that heals primarily, has minimal fat necrosis because you've used the well-perfused tissue rather than that portion of tissue which may look viable clinically but goes on to develop fat necrosis. So if you obviate any risks of fat necrosis or wound breakdowns, you've cut patient cost and hospital costs. So the insurance companies benefit tremendously from this in the long term, although I think they may still have to catch up with the technology and realize its importance. But it can be a real money saver, save you having comeback procedures for debridements, wound care with home health nurses, debriding and treating wounds in the home environment, multiple visits back to the surgeon's office for debridement and so on. And we've seen a dramatic reduction in fat necrosis, both clinically and radiologically, and much less by way of wound healing problems in these patients. So it's been an enormous step forward for us in reducing patient morbidity. At my initial consultation with a patient, whether it's in the breast cancer center, we have a multidisciplinary breast cancer center, or here in the office for a consultation, I sit down and talk about the complications of these procedures. And when I get to the point of skin and fat necrosis, mastectomy skin flap necrosis, which I talk about in detail and I give them percentages, I talk to them, that's the point at which I introduce the SPY camera. And I talk to them about the benefits of the SPY, how much it's improved and reduced our morbidity, and what a benefit that is to them. And we talk about patient safety, about how this is an innocuous procedure. It takes minutes during the operation, and that's another benefit of it, is it's so quick and easy to use. It's been an absolutely wonderful innovation for us. You know, we've relied on fluorescein and laser Doppler flow monitoring and so on for so long, trying to use these other modalities to show us what tissue is viable, and nothing is terribly good intraoperatively. And whether it's a breast reconstruction and a mastectomy, or whether you're doing a pedicled fasciocutaneous flap in a leg to cover a fracture, a compound fracture for the orthopedic service, or a scalp flap for the neurosurgeons, this is technology that can be applied all over the body for plastic surgical patients. And when you add all the benefits of multiple patients together, this thing pays for itself over and over again in a relatively short time, by way of reduced morbidity, patient hospital costs, and so on. And I'd urge as many plastic surgeons as possible to get on board with this technology, because I don't think there's anything quite like it that we've ever seen before. What's really impressed me about it more than anything, I think, is not just the ease of use, but the tremendous accuracy that it has in predicting what's going to be bad. Again, when you look back on one's learning curve, there are those times where you think, this looks great and I'm going to keep the skin or keep that portion of the flap. And a week, 10 days later, you're looking at a dead portion of a flap or a necrotic piece of mastectomy skin. And you go back, and I've got one patient where I correlated it with my preoperative photograph of the patient's breast, the intraoperative photograph I took, and then the SPY image, and then looked at the photograph of the postoperative blistering, and it correlated perfectly with what the SPY camera told me. I listened to myself rather than the camera, and I paid the price, and of course so did the patient. And it's that kind of thing that makes you realize how precise this technology can be. It's very interesting, and I think the potential for this in the future is great. It gives you a real-time intraoperative assessment of what's alive and what isn't, or what's going to be reliable and what isn't. And what SPY does is it gives you that confidence that a lack of clinical judgment would not give you. And it also, even when you are experienced, it enables you to see little pitfalls and traps waiting for you. Even when you've got years of experience, it's sometimes difficult to tell what tissue is going to survive well and what won't, and what may be more prone to fat necrosis. And a young surgeon can learn an enormous amount from this, I think. I think it's just the most marvelous technology I've ever seen. It's wonderful.